So there are nearly 400 of you from 32 different countries around the world who registered for this webinar. This is really exciting. So I thank you for joining me and the International Hyperhidrosis Society as we take a deep dive exploring oral medications that are commonly used for the treatment of excessive sweating and hyperhidrosis. This live webinar will be moderated by me, Lisa J Pieretti. I'm the Executive Director and co-founder of the International Hyperhidrosis Society. We are blessed with the expert panelists, Dr. Deanna Glaser and Dr. Adelaide Hebert, who have graciously joined us. Today, we will discuss how oral medications work, when and why they may be recommended, how to use them safely, and for the most benefit in managing excessive sweating and hyperhidrosis. I will ask of the questions to the doctors, and they will share their experiences and how they approach their patients' management of hyperhidrosis. Both of these physicians are very active and have a very engaged patient population for hyperhidrosis, so they have lots of experience to share. Many of you who attendees here have provided your questions during the registration process. We will address as many of your questions as possible in the time we have together. My colleague and International Hyperhidrosis Society educator, Angela Ballard, is a registered nurse and hyperhidrosis researcher. She will be monitoring additional questions in the Q&A tab. If time allows, and we have not answered a specific question, she will let us know this towards the end of our time together. The information provided during this webinar is not intended or implied to be a substitute for professional medical advice or as a medical diagnosis or treatment. It is shared for educational purposes only. An educated patient is an empowered patient. Viewers assume full responsibility for if and how they choose to use this information. Always seek the advice of your physician or other qualified healthcare provider before starting any new treatment, or importantly, before discontinuing an existing treatment. Talk with your healthcare provider about any questions you may have regarding your medical condition. And to answer a very popular question, yes, this webinar is being recorded and will be made available to the public in a few weeks. Today's attendees will receive early notification and access to the recording, so please watch your email for this early access. Now, I'm honored to introduce my friends and expert panelists, Dr. Adelaide Hebert and Dr. Deanna Glaser. Dr. Adelaide Hebert is a certified in dermatology and pediatric dermatology and one of the founding members of the International Hyperhidrosis Society. She's a former president of the Women's Dermatology Society, a professor in the Department of Dermatology and Pediatrics, and an associate professor in the Division of Craniofacial Growth and Development, Pediatric Dentistry at the University of Texas Health McGovern Medical School in Houston, Texas. In addition, she is a consulting staff member at the University of Texas Anderson Cancer Center. Dr. Hebert has spoken on numerous dermatologic issues around the globe, including hyperhidrosis, with a special focus on children and adolescents who struggle with this condition. Dr. Hebert has been an active dermatologist for over 30 years and has treated thousands of hyperhidrosis patients. She believes that finding effective treatments that improve the quality of lives for patients who sweat excessively is both remarkable and deeply rewarding. Thank you, Dr. Hebert, for joining us.
Thank you, Lisa.
Dr. Deanna Glaser is an active dermatologist and has been in practice for more than 30 years. She is president of the International Hyperhidrosis Society, as well as one of its founding board members. She is currently a professor of dermatology, internal medicine, and alternology. You're going to have to help me with that one day, Deanna. Thank you. And interim chairman of the Department of Dermatology at St. Louis University School of Medicine. She is also the director of cosmetic and laser surgery in the Department of Dermatology and the director of dermatology research services at St. Louis University, Missouri, here in the USA. She has lectured about the mechanism, diagnosis, and treatment of hyperhidrosis at numerous professional education forums on behalf of the International Hyperhidrosis Society, the American Academy of Dermatology, and other dermatologic associations. She is an indisputably world-renowned authority on hyperhidrosis and at the forefront of novel hyperhidrosis research. She is a strong advocate of hyperhidrosis awareness and has been influential in treating millions of hyperhidrosis sufferers. Thank you, Deanna.
Thank you.
So all of you who are listening, we're over 100 now who are piling into the room with us. Please join me in thanking both of these doctors for their dedication to the International Hyperhidrosis Society and care for our global community. You can voice your gratitude in the chat and it will be preserved forever, and I'll share it with our experts later. Okay, let's get started. So the first question I have here is, and I'll ask Deanna if you'd like to start, what are the different oral medications that are commonly prescribed? And can you tell us the brand name and generic names for each?
Yeah, well, there are several medications that we tend to prescribe, including things like anticholinergics. So glycopyrrolate, oxybutynin, that would be Robenol, and ditropan. There are other anticholinergic agents that can be used as well, but the first two are the ones that we tend to use most commonly, and there are some that are available in other countries that we don't have in the USA. There are also things like beta blockers that we might use in certain instances. So propranolol would be maybe a very common one. And then there's also things like alpha adrenergic agents, such as clonidine, that have some very specific indications or times that we use them to treat excessive sweating. So those, I would say, are probably the most common.
Terrific. Dr. Hebert, do you have any to add?
No, I would completely agree with Dr. Glaser. And I would say, as a pediatric dermatologist, I have a considerable experience using these even in the youngest children, at least the first two drugs, the glycopyrrolate and the oxybutynin. I do use propranolol in very small babies for another condition called infantile hemangiomas. I don't usually use that drug in the youngest of children, but I think it's a great alternative. And that's a drug that's been around since 1976. I don't remember the exact dates for oxybutynin, but I know it's an older drug. I know it's been around since I was in medical school. And I'm sure glycopyrrolate has been around even before I was in medical school. So these are not new drugs. I want to reinforce the fact that we have years of experience in a variety of disease states where our colleagues within the House of Medicine have used these drugs very successfully and we've learned to be very adept with them. We can monitor for the side effects, which are not too extreme, but
well, before you go there, hold on.
Okay.
You're answering all my questions.
Sorry.
That's
Sorry.
okay. That's okay. So Dr. Hebert, let me ask you this, because you kind of touched on this. So what are some of the other indications that these drugs are approved for? Just for example, like what are they commonly used and then sort of got adopted into the hyperhidrosis realm?
Well, glycopyrrolate was originally for excessive secretions, particularly GI secretions. I'd say right now the number one use that my colleagues find it for is when a patient has a tracheotomy. If they can't breathe, then they have to have a little hole cut in here, either from years of smoking, trauma, a whole host of reasons. They make a lot of secretions which break down the skin and make the trach access impaired. So as a result, they go on the glycopyrrolate and the secretions dry up and they can maintain their skin integrity. Oxybutynin, on the other hand, at least in the pediatric realm, is the number one drug used for bedwetting. As children mature and learn to have better bladder control, but they can't quite make it through the night, this is the number one go-to drug. So pediatricians have used this for years with considerable comfort.
Very interesting. Deanna, anything to add for the other indications that these are used for?
Yeah, I think, the anticholinergics are oftentimes used for peptic ulcer disease, overactive bladder. So as Dr. Hebert said, there's a lot of indications. There's a huge history of use, and we understand how these drugs work and how to manage them. When you look at a drug like propranolol, which is a beta blocker, it's oftentimes used maybe for high blood pressure. It might be used for cardiac disease, after a myocardial infarction. So it has a lot of uses as well. And that one really is used more intermittently. And then when you look at like something such as clonidine, clonidine may be used as an antihypertensive medicine, a blood pressure medicine, but it can be helpful in very specific types of situations within hyperhidrosis. And it's really, I think, incumbent upon not only us as physicians, but for patients to really understand what these drugs are doing and how to best use them to improve their condition.
Wonderful. Thank you so much. I think it's really important for our community to kind of have a holistic idea of these medications. So are all the oral medications for hyperhidrosis prescription only, Dr. Hebert?
All the ones that we've talked about so far do happen to be prescription drugs. But one good thing about these prescription drugs is because they've been around for a long time, they're usually generic. They're often very cost effective. They're on almost every pharmacy list for insurance purposes. So we're very fortunate that most patients can get these at a reasonable cost, or at least in my environment, that's certainly been the case. So again, very readily available. Over-the-counter drugs, I'm not so sure in terms of oral medications. There's one that I have at least been aware of. That may change over time, but currently I don't have a specific go-to over-the-counter product that I would recommend.
Deanna, do you know?
Yeah, I agree. No, I don't think I know of any. I mean, if somebody is sweating because they're in pain, is taking a pain reliever like an ibuprofen or something, that may improve that type of sweating. But I think most of our listeners really suffer from hyperhidrosis that, is more idiopathic. And so I think we don't really have those other types of drugs that are more specific to a specific type of sweating.
Great. So Deanna, I'll stay with you. What are the major differences between the various options of oral medications?
Well, the one that we use most commonly, as I think both of us alluded to, are the anticholinergics, the glycopyrrolate and the oxybutynin. And the reason for that is they block the signal that comes from the nerve that tells the sweat gland that it's time to sweat. And we know that in people who have hyperhidrosis, that's happening much too frequently and more often than it should, and more severely. So blocking that little signal from the nerve to the sweat gland makes the most sense, right? Because it's really tackling the problem at its source of the sweating. When you look at something like propranolol or the beta blocker, that kind of helps to calm down the system. It slows down the heart rate, slows down things. So a lot of musicians use it before, say, a symphony production, or a lot of surgeons use it prior to a very technical and detailed surgery, like maybe a microvascular surgery or something. So that just kind of slows things down. People are less agitated. And so it can really help sweating maybe when you know that you're going to be agitated or nervous, like you have a job interview or you're meeting a new date for the first time, things like that. And you can take it for that. The clonidine, which is, we mentioned, used for hypertension, can really, for whatever reason, and I don't quite understand it myself, maybe Dr. Hebert can fill us in, but it really helps people who have menopausal sweating, sweating that's related to other medications like anti-anxiety medicines, antidepressant medicines. And then for some reason, I find it fairly useful for craniofacial, for scalp sweating and facial sweating. So I honestly don't quite understand it. I know how to use it, and I'm grateful that it helps my patients, but I'm not quite sure exactly what it's doing.
That is so fascinating. See, I always learn from you guys. So my next question is it bounces right off of that. One question that we were asked over and over again by the registrants was, if I have this type of hyperhidrosis, whether it's on my face, my hands, my back, I'm post-ETS, can these medications be an option for me? So we have lots more questions to go, but I just want to make sure that folks here listening, they may want to know, is this relevant to me? So Dr. Hebert, do you want to start with that?
Yes, I'm going to first go on record that I'm not a big fan of ETS surgery. So if anybody's considering it, I hope you will speak to a specialist who doesn't do ETS, because it started in Sweden. It's outlawed there because there were so many patients with complications. And I'm sure Dr. Glaser and I both treat patients who have had ETS and have had compensatory sweating in other areas. Absolutely, we can treat these patients with the oral anticholinergics. We do sometimes use Botox also if it's a focal area that's particularly troublesome or they don't tolerate the oral medicines. But absolutely, at least I have found you can use these medications. But ideally, I would rather spend hours talking a patient out of ETS surgery because I think the risk-benefit ratio, at least in the patients that I see, which are the ones that have the complications of compensatory sweating, it's really not worth it. And I've seen too many patients who tell me they wish they'd never had the surgery. So I just put that out there. I know it has helped some patients and for some it is a last resort, but in general, we try to avoid the problem that might make the sweating more challenging for the patient.
Mhm. Dr. Glaser, when you think about the different focal areas, how do you assign a different oral medication?
You know, for me, like I said, the clonidine seems to be most helpful in craniofacial, and especially those that are related to menopause or other medications. It's like I said, especially anti-anxiety and antidepressants. But I think the real key to remember is that these are not usually used alone, and they're oftentimes combined with other therapies to optimize the benefits and minimize the side effects. So the specific question about after ETS and compensatory sweating, I think it's a huge challenge, and I should say, make patients back to where they were before the surgery. I mean, I might make them a little better by using multiple different therapies, but I can't get them back to where they were before. And most of them are still dissatisfied with the treatment. And so I think it's important to remember that we're still limited by the side effects of the medications, how much we can use, and that it may take a lot of different therapies to really get the best results for an individual patient. And that's tiring. That's exhausting for someone who's trying to manage a chronic problem and having to use many, many different treatments to make them somewhat better, a little better, a lot better. But, it's tiring. And so we understand that.
Mhm. Right. And that just tells me that it's so important to give feedback to your physician, your prescriber, and tell them what's working for you. So why, specifically, this is another question that comes up a lot. When someone is taking anti-anxiety medication, can they also take this along with it, or would it replace it, or what are your feelings on that? Dr. Hebert, I'll ask you first.
Well, certainly it depends on which anti-anxiety medicine they're taking, but it is well known and it's published, not by me or Dr. Glaser, that many patients who have hyperhidrosis have anxiety. So first and foremost, I think patients need to understand certain things in the medical arena travel together, and this is one of them. So some patients do need the benefit of an anti-anxiety agent, perhaps some psychotherapy also to benefit that part of the care. But yes, we can treat them with anticholinergics. Again, I'm carefully weighing because I don't know every new anti-anxiety medicine that might come out. So I always have to check the profile of the medicine, make sure we don't have a drug-drug interaction. But I think we want to optimize these patients' global care. I myself don't prescribe anti-anxiety drugs. I don't know if Dr. Glaser does. I think that's best handled by a professional who deals with that part of medicine. But indeed, if the patient is enhanced in terms of their quality of life and so forth, I would encourage them to get that part of their care addressed. And I might start them on the anticholinergic and actually send them for the anti-anxiety medicine to be added on. It can go both ways. They can come to me on the anti-anxiety medicine, or I may think that part that I'm not going to manage can be managed, but I need someone who's a specialist to assist me with that component of care.
Dr. Glaser, anything to add?
No, sometimes it's hard to know what's the cause and what's the effect. And so many people with hyperhidrosis definitely have some anxiety about the sweating, but some people just have anxiety disorders as well as hyperhidrosis. And I think that's what Dr. Hebert was alluding to. And so if you've got an anxiety disorder, you need to treat that just like any other medical condition. But it's natural for someone when they're anxious about meeting someone, having to do a task that they know they don't do well because of their sweating, that induces anxiety in and of itself. So, trying to get the hyperhidrosis treated can then actually improve that type of anxiety. So It is definitely more complicated than it might seem on the surface.
Yeah. Well, that's again, it comes back to the relationship, the doctor-patient relationship has to be a team. So it seems like the oral medications have been around for a while. Have any of them been, the manufacturer's been submitted and reviewed by the FDA specifically for the treatment of excessive sweating? Do we know? I don't know of any. Do you know of any?
I am not aware of that, but it's important to remember whether something's FDA approved or not. As a physician and a trained medical profession, we can certainly use medications to treat diseases and problems that doesn't have that indication. And lots of drugs are used off-label. An antibiotic may be approved to treat one type of pneumonia, but it might be used to treat a different type of infection. So these are very common, and a lot of times patients are not even aware of what's exactly on label or off label use, because it's, they trust the physician to know what they're doing and prescribing them a drug or a therapy that's going to help their condition. But I don't think any are FDA approved. And sometimes that affects us in terms of insurance coverage, because certainly now some of the insurances are saying, well, we're not going to cover that because it's not on label or it's not an approved indication. And so I think that's where that hurts us. Not that we can't use them and use them safely and effectively, but sometimes we do get that pushback from the insurance.
And I have some patients, I don't know if this is because I have some folks who email me, I've tried everything, I've tried every oral medication and it didn't work. And sometimes I wonder if there's not a standard among, like maybe they tried it, but they didn't try it with a physician like you two that had the right dosage and the right protocol.
I personally find that oftentimes if I really dig into the history with the patient, it was usually used as a monotherapy. And I really want to reiterate that it's so important to use all of the therapies that we have to really optimize the outcome and to minimize those side effects. And so I don't think the answer for most of our patients is to only use an oral medication. But I do think it's important for people to understand that oral medications added to other things can be incredibly valuable. I don't know, Dr. Hebert, what do you think?
Well, I would say in the majority of my pediatric patients, they respond very well to oral medications. They don't seem to yet need to have other therapies in all cases. Now, I like Dr. Glaser, I use all options because I think there are patients who warrant other options or combination options. But I think many of the pediatric patients do very well on the anticholinergic agents. And it's one of the most refilled on time medications that I prescribe because it's so impactful. And the patients tell me, I don't want to run out of that medications, but because it's truly changed my life. So I use the medications again off label, and I have to agree with Dr. Glaser. Sometimes insurance pays that card that is not FDA approved, especially in pediatric patients. And I think that's really tragic because 80% of all prescribing within the realm of pediatrics is truly off label. So we have to fight for our patients, and it does take up a lot of our time, but I think it's so important that these patients have the option for therapy just like anyone else.
Right.
And I just want to add one thing onto what Dr. Hebert said, is that physicians do fight for their patients and the offices do, but it doesn't replace the advocacy that the patient needs to play a role in with their insurance company. You cannot rely solely on a medical practice to be the only advocate. And so patients need to be involved with getting in touch with their insurance, asking to see the exact policy and really, advocate for themselves, because to some degree, the squeaky wheel is going to get the grease, it's just the way it is. So I think that's really important.
I agree. I would love for us to have a webinar like this all about navigating insurance here in the US, and then maybe country by country as they need it. So Deanna, you mentioned about combining. We talked about combining treatments, and I would love for you to give us some examples of when you say you have a patient Just give me some examples of combining. So say a mirror dry and oral meds, or Botox and oral meds. Tell me a story.
A lot of time, it might be a patient who has axillary sweating, palmar sweating, maybe some other area, inframammary. And so we might use something like either a Botox for the underarms, which is FDA approved for there and a little bit easier to get with the insurance. We may use a topical like aluminum chloride at nighttime. That drug should always be applied at nighttime to dry skin, not in the morning time. And then maybe like an over-the-counter antiperspirant in the morning to the same area. We might use a topical antiperspirant to the inframammary area. We may use iontophoresis for the hand sweating, which I think is really one of the best, and then supplement it with a very low dose but consistent dose of an anticholinergic like the glycopyrrolate or the oxybutynin. And when you really start combining all of those, you need less oral medications. You can usually get better results. But again, that's a lot of work for people. And I get that, but that's how we achieve the best results.
Dr. Hebert?
Yes, I would agree. I mix and match all the time. And when a patient has a side effect that they feel is intolerable, that's when often we will begin to expand the therapeutic arena that the patient will undertake. It is hard sometimes to do multiple things for a single patient. It takes up a lot of their time. But again, because I think we're so vested in getting these patients to a point where they just live a normal life, they're really happy that we have taken the time and guided them through the steps to improve their overall quality of life, reduce their sweating, really understand what they have to do when and what they have to do where is such a critical thing to the success. And I know many patients have said just that they're so interested to find somebody who's actually interested in this problem and seems to be knowledgeable because they've been to their family practice doctor, or let's say the pediatrician, who knows very little about excessive sweating, or they dismiss it and just say that's normal. It's not normal if you're really having excessive sweating that drives you to be more reclusive or sweat all the time and ruin your clothes and shoes. So this is just an arena where I think we make a huge impact.
I agree.
And not only do some of the physicians not know how to treat it or that it's important, but that sometimes they're just giving misinformation, like, don't worry about it, you'll outgrow it. And we know from published research that most people don't outgrow it. So part of our job is to find a therapy that can be safely used for many years, right? And that is still effective. And even some physicians even some dermatologists may tell a person to occlude their dry sol or their aluminum chloride to their underarms at night.
That means wrap it up.
Wrap it up, exactly. Maybe some plastic wrap or something like that. And that only increases the irritation and the redness and the burning and the stinging. And so I would also like to empower our patients here who are on the chat with us and on the line to, if it doesn't sound right or it's not helping, find another provider who knows more about it. So, not every person is an expert in every disease. And so, I certainly recognize my limitations and will send patients to someplace else or somebody else who can handle that problem better. But be sure that you have that power to say, that doesn't sound right. I'm going to find someone else.
Do you see any patterns in the dosages? Like, meaning if someone has one focal area, is the dosage different than if someone has multiple areas or all over sweating? Any patterns?
So I will say I actually did a study and we did not find that the dosage really varied or that we could predict based on the number of areas or the the severity of the person's sweating. And sometimes I find patients are very sensitive and we need very small doses. And I find some patients who need larger doses. And we also didn't find a correlation between their size, their weight,
that was my next question,
their BMI, And so it's very interesting, but I think that's very similar to other medications and other therapies that we use. Some people need a very low dose and some people need a higher dose. So I think, yeah, that there is no correlation in my opinion. There might be one for pediatrics.
Right.
Dr. Hebert, what do
Well, I
you
would say in pediatrics, certainly weight is a big factor. And as the child grows, we sometimes do have to alter the dose. Also, I'm in Texas where it's very hot in the summer. And I allow my patients to increase the dose within a safe range in the hottest months of the year, as long as they don't go outside and get too hot and not able to sweat and they would have heat stroke. I don't want that. But I do allow patients flexibility. I also allow them weekend holidays. If they don't want to take it on the weekends, that's fine. But I think with children, we do, and I do a very small dose and gradually increase it over time. It seems to work very well. Patients find their sort of sweet spot, if you will, and they know what they can take and they know where they can push up to the limit where they get very good results, but very few side effects. They easily find that, and they like having a little flexibility with the pill taking. They don't have to take it like an antihypertensive every day if you're using the anticholinergic agent. So that flexibility, the dose alignment with what they're doing that day, I think this is a great appreciation, a greatly appreciated moment in medicine for many patients to have that bit of control that they don't get from many other aspects of their excess sweating experience.
So is that the case, like you can skip a day or something with all of the medication, all the oral medications, or just for like a glycopyrrolate?
Well, I would say for the glycopyrrolate, if the kids aren't going to school and they're not worried about sweating or being embarrassed, I give them a holiday on the weekend if they wish for it. I don't know what Dr. Glaser's policy. I don't seem to get an attenuation in response, a reduction in response because they go back to it on Monday. It seems to work very well like that. It seems to be a dose-related response. You take the medicine, you get the response. But I'd love to hear Dr. Glaser's input on that as well.
Yeah, me too.
I mean, obviously patients can take drugs as they see that it works best for them, but I generally do like them to take my adults on a regular basis to maintain it. I will say the caveat with that would be with the propranolol, which really works best when it's only taken before a specific event. So if you know that every time you have to report to your boss that you're going to really be sweating more, then they should take that about 30 to 60 minutes before that event. And I have found when patients have taken it on a regular basis, it doesn't work as well. I think the clonidine also seems to need to be taken on a regular basis. And the one thing about that drug, which is important, is that when it's used for high blood pressure, if you start and stop that drug, your blood pressure can actually rebound and go very, very high and lead to strokes and other problems. So each medicine is different and each age group is different. So I think it's important as we're discussing this to make sure that the patients know, or the public here knows, that they really need to discuss these options with their physician because each drug is different.
Let's talk about the different side effects that the different drugs get. And Deanna, Dr. Hebert, who would like to start?
Well, I'll go ahead and start. I think that dry mouth is probably one of the really common impacts of oral glycopyrrolate and oxybutynin. But many patients learn to carry a water bottle, which is not considered abnormal. Everybody has a water bottle these days. I mean, I have mine sitting right here and I'm not on an anticholinergic. We teach them how to use proper oral rinses that can leave a clear film in the mouth and reduce the dryness. Most people compensate after a while. If we have to, we can add in pilocarpine, a drug that happens to increase saliva in the mouth. But we just work around the side effects. But I'd say dry mouth, perhaps dry eyes. Those are the two most common. Occasionally constipation. We ask them for a change in diet with a little bit more fiber, taking in more, drinking coffee if they're old enough to do that. We just work around it. I think we manage all of these with just guidance and very practical advice.
Deanna?
Yeah, I agree. Those are the most common with the anticholinergics: dry mouth, dry eyes, some constipation. The other thing, and so, right, you can use eye drops, you can drink water, you can have films, you can do all these different kinds of things, but it really does need to be at a minimum and bearable. I think, one thing we always worry about is high dosages of medications, and we want to keep the doses as low as possible to improve the safety profile and improve the ability that we can use it for a long time for our patients. Like I mentioned, patients usually people don't outgrow this. So we need to have these medicines available. And we really do like to keep the side effects low. Anticholinergics have been associated with some hyperactivity and some changes in mental status where it might slow you down a little bit. That tends to occur in both the very young user and the very old user. So a time that I'm especially cautious about using the lowest doses possible. And even between the anticholinergic drugs, there are some differences. And some people respond better to one, and some people respond better to another. So, work with a physician and let them try different combinations and different medications to really try to give that best result. Side effects of the propranolol, if you take it 30 to 60 minutes before you know you're going to be sweating, it may slow your heart rate down so much that you may not be as with it mentally. You may not be able to answer questions quite as quickly. It can lower your blood pressure. And if you stand up quickly, you may feel very lightheaded. So usually I'll have patients take a test dose before they need to have it at the workplace or whatever the event is. I mentioned the severe changes in blood pressure with clonidine that can happen if someone really does have high blood pressure and they stop it suddenly. They can really have what's called rebound hypertension that can, in some cases, be quite serious. So again, we use these medicines, they're important, but it's important that I think those who are taking them really follow their physicians or their prescribers' advice.
Deanna, many years ago, you told me a story or had a patient that I'll never forget, and it was a young athlete, and it was in the hot St. Louis summer, and you told me how you have to really be careful with where I'm going here. Tell me.
Yeah, I think, if we're reducing your sweating, and remember that with these anticholinergics, and we've mentioned that they're FDA approved to treat other conditions, one of their side effects is to reduce sweating. And so we're trying to target that one little side effect and none of the others. But if we really are reducing sweating, I tend to worry about high school athletes, football players. They go out and they start practicing in late July, mid-August. It's hot. They've got all this equipment on. Their coach doesn't really want to hear a bunch of complaining that I'm not sweating well. And, so I worry about those. I worry about some of my outdoor workers, and like Dr. Hebert, it's hot and humid in St. Louis during the summer, and they've got, these specific uniforms that they have to wear, and they're out on the tar, laying roads down, and it's hot. And we need to be sure that they're sweating, that they're urinating, that they're drinking, and they have access to all of that. When they're little kids, parents oftentimes will monitor that. It's the teenagers that kind of make me a little bit more nervous. I don't know about you.
Well, in Texas, football is king, and the clothing they wear, between the shoulder pads and the lycra pants, the clothing doesn't help them to sweat either. So it's a combination of, we give them an anticholinergic, they have outer sportswear that isn't very friendly in the environment of a great deal of humidity and heat, and then it's just a little bit too much. So I usually tell the mother, or I give the coach a note, and just if the child's feeling too hot, they have to get off the field, and it has to be something. And even the gym teacher, we try to make that communication an imperative, because people have heat stroke that are not on anticholinergic agents in Texas, and we're very aware of the severity of that, and we respect it and take precautions. And again, education, as Dr. Glaser said, it's so key. Everything we do is related to educating the patient, providing the best, safest, and most effective therapy that is available to us to give to them.
Yeah. Just yesterday, a sufferer emailed me, said, I can't work. The temperature at work is 77 degrees. And how do I get my employer to cool it off? And so that would probably be someone who should not have anticholinergics because they're just really going to suffer greatly. What are there some contraindications to note when prescribing different oral medications? And just a note about this conversation we're having about the temperature. I love it because we have some people on the call today that are from very hot climates in India and Mexico, Ecuador. So I'm really glad that we're talking about the oral medications and talking about the climate. So back to the contraindications. What is the narrow angle glaucoma? Is that something or okay? And I'll leave it to you, Dr. Glaser, if you don't mind.
Right, so that's a big one, narrow angle glaucoma, but it's only untreated narrow angle glaucoma. So if it's been treated surgically, they can go back on because they've opened up the passage for the ocular fluid. With propranolol, certain like bronchial diseases asthma can be worsened significantly with those. With propranolol, if somebody has very bad psoriasis, it could make them worse. So there are some, and they're kind of specific to maybe each individual that we would do. And then there can be some drug-to-drug interactions, as Dr. Hebert alluded to when we first started, that we need to know. And actually, we need patients to be honest with us of what medications and non-medications they're taking. Whether it's supplements, whether it's drugs. I mean, we really need to understand that so that we can provide a safe therapeutic approach to their problem.
Right. Are any of these drugs that can be impacted by drinking or eating grapefruit? I'm always surprised when there's all of a sudden, don't have grapefruit, right?
No? I don't think so, but yeah.
No, that there's a certain system in the liver that uses a metabolic pathway. Drugs like that are over the counter, such as Tagamet, is one where you really shouldn't take it with grapefruit. Cyclosporin, a drug that is used in the transplant world, but we also use it off label in atopic dermatitis, on label in psoriasis. You can't take grapefruit, but I think those are very unique arenas, and generally the pharmacist will cross-reference any drug that we prescribe with what patient is on if they've used the same pharmacy. Hopefully they've been educated about that, but that's a narrow range of drugs, but they are very impactful to the patient because it can raise drug levels, and it's important to recognize. But I'm not aware of any of these drugs that are impacted by grapefruit. And grapefruit is the state fruit of Texas. So just throw that out there.
Thank you. We focus on primary focal hyperhidrosis. Just quickly, are these medications, can they be used to treat night sweating, for example?
I think we need to know the cause of night sweat. Certainly if you have tuberculosis, Dr. Glaser and I have not mentioned any medicines to date that would be very efficacious in night sweats, but it's one of the key things you would think about if a patient came in. The first thing they said is, I'm sweating at night. But also menopause, is your diabetes poorly controlled? Is your blood sugar going up at night because your insulin dose is not correct during that time frame? We really have to find the reason that the person is having night sweats, because classically when you go to sleep, you don't sweat. I think that's a whole arena of evaluation that would be undertaken, at least before I would start to prescribe. I mean, they would have to fit in the criteria that we currently use for primary focal hyperhidrosis for me to use one of these drugs. If I think it's another causation, I'm going to make sure that I do an evaluation. Could it be thyroid disease? There's a whole host of things that we might think about, and it may fall beyond the scope of what we do as dermatologists, and we rely on our colleagues either in internal medicine, family practice, neurology, whatever specialty we deem being the most appropriate for that person's review of systems and history. And we'd let the other physician assist us in trying to elucidate the real causation of the night sweats.
Anything to add, Dr. Glaser?
No, I think that's very important. And, it's other symptoms that the person might be having. So someone who's very tired, fatigued, and having night sweats, the cough with maybe tuberculosis, but, we think of cancers sometimes causing night sweats. So there's a whole range of things. And I don't want everybody who's on this webinar with us to run thinking they have cancer or tuberculosis or other things. But, when it starts later in life, it's brand new. It's not that classic child, teenage, young adult, it's, different timing, then it's important to get an evaluation to be sure that there's nothing else going on.
Right. And for anyone out there who's interested in more information on night sweats, just go to sweathelp.org and click on the section all about night sweating, and you'll see a nice discussion like Dr. Hebert and Dr. Glaser put forth here. Just very, very quickly, some people have face sweating when they eat. Dr. Glaser, I know this is one of your specialties. This is called Frey syndrome, or gustatory sweating. Can oral medications be used to treat that, or would you suggest something else?
So it could be used, but there are other treatments that are so superior. And this is a place that I think botulinum toxin or Botox, Dysport, Xeomin, Jeuveau, any of the botulinum toxin A molecules for the physicians on the call. I think that just trumps any other treatment. It can last cause the sweating to stop for a year to a year and a half, 2 years, can be relatively small doses. So to me, my first treatment of choice for sweating in this area on the face, especially with eating, chewing, thinking about food, it's botulinum toxin injections. And it's usually related to some sort of trauma. So somebody who's had a facelift, someone who's had a parotid surgery, someone who's had an injury, like I had a person who got smacked in the face with a volleyball spike and they developed Frey syndrome after that. And anytime they thought about food, it just pours down sweating. And so it's really socially disabling. But botulinum toxin injection is just simply amazing.
Mm-hmm. Great. I think that's really helpful. And we do discuss that on Sweat Help also. I just love hearing you describe it. And one thing that Dr. Glaser just did that I would love everyone to take notice of is that she only touched one side of her face. So we know that hyperhidrosis, focal hyperhidrosis, is a balanced condition. So it affects both sides of your body. That's one of the highlights of it. So I am now going to turn to Angela and ask her if she has any questions that we need to, and Angela, you can unmic and let us know if there are any questions that that came in that we haven't answered.
Okay. Yes, I have been keeping track of them. One question that has come up a couple times is, are there long-term side effects? So people who've been taking oral medications for their hyperhidrosis for many years, are there long-term side effects that people need to be aware of?
So I'll start with that. There's been, and certainly for the older individuals, there have been some papers that higher doses of anticholinergics in the elderly, and I'll let everybody here on this webinar determine what that means to them, may be associated with some dementia, but it's very hard to understand if that's a cause and effect, or that older individuals, elderly, may be at higher risk for having dementia and it may not be a cause and effect, which I think is one of the reasons you'll hear Dr. Hebert and I consistently say we want to keep the doses as low as we can by using other therapies and by other modalities so that we can really minimize those risks. But I will also say that we want someone to have their hyperhidrosis and their sweating condition treated adequately. So we're not trying to hide from the doses that are required, but we're also trying to keep the doses low as possible so that we can maintain the therapy for our patients. I don't know for children if there's some specific long-term risk that you worry about.
No, I really don't. I would say the major worry I would have is the one of overheating in the sports arena and just the environment in which I practice. But I think there is considerable social isolation and lack of personal well-being in untreated patients. And while we haven't focused on that very much, not treating these patients, I think is a cause of considerable concern to them, and they're not leading a full life. And I think Dr. Glaser and I have arranged for therapies that can really be life altering. These patients really come to us with a problem they have not been able to solve on their own. They perhaps have seen other physicians, and we guide them in a therapy or a group of therapies that really turns their life around in many cases. I find patients tell me that all the time. They're just so happy they found someone who's generally knowledgeable and interested in their problem, that we have therapies that they can get covered in their insurance. Their life is much better as a result.
Right. And we know that some side effects can be seen in some patients and not others. So, that's why we ask people to come back to the office to, look at how they're doing, what kinds of problems they might be having. And, we don't just keep prescribing them in infinity. We like to make sure that it's still an appropriate dose and an appropriate therapy for them.
Question that keeps coming up over time, can you become tolerant of one medication and then need to increase the dose or switch to another one?
I don't think with the anticholinergics that's been a major problem. Now, I have had to increase the dose as the patient grows. That's just a weight-based issue, but I have not seen a lot of tolerance in terms of the patients I've cared for. Many of the patients stay on the same dose for years, and they feel they're very nicely controlled. They very much appreciate the fact that these drugs are available and that they can stay on them. As long as they take them, they feel very normal, and they describe that as a term on many occasions as I see them in follow-up. So I'm not too worried, at least based on the current information available. And certainly these drugs, as I mentioned earlier, have been around for a very long time. And if there were side effects that were profound, I think we in the medical community would be aware of them by this point.
And I would agree with my colleague here that oftentimes you don't need to increase. And sometimes just the disease of hyperhidrosis kind of fluctuates, and maybe the situation fluctuates. So, you're starting a new job, you've gotten divorced, and you're trying to go dating again. And so maybe it's the situation that has changed, and then we may have to change the therapies or decrease the dose, increase the dose. But I think overall, it's a stable dosing, I would say, overall for adults.
Angela, what's next?
Are there any of these oral medications for hyperhidrosis that can be used while someone is pregnant?
So propranolol can be used. First off, I'll say any medication should be run past the OBGYN, no matter what we're saying here. Oxybutynin is a class B in pregnancy, which means at least it has some studies. And so when I do have someone, a female who's trying to get pregnant or is wanting to get pregnant, I will, if I'm choosing an anticholinergic, I will use oxybutynin over glycopyrrolate.
I would agree. I think certainly we haven't had huge studies in the pregnant population, but we try to pick the safest drug. And like Dr. Glaser, we always run this by the OB. We want to be exceedingly thoughtful and careful about patients' overall well-being and well-being of their unborn child. So that is a criteria that I always follow as well.
Another question that has been asked a couple times, does it take a little while for an oral medication to start taking effect against sweating? Like, do you need to wait a couple weeks, for example?
So I'll start for the adults. Generally, it takes us a while to find the right dose. The effect of the drug is usually within about 3 to 5 doses, but usually we're starting low dose and then increasing the dose every couple of weeks based on the side effects that the patient might be having or not having, how severe the side effects are. And so then we're gradually escalating the dose, again, to reach a point where the patient is getting benefit, but keeping the dose as low as possible. And I assume that you're doing that in a similar fashion with the pediatrics.
This is true. I mean, we do have to work up to the well-tolerated, but also effective dose. And we usually find that very quickly, but I have the patients tell me within about 3 to 5 days, they already feel a perceptible difference. It might not be the perfect difference that they're seeking because we're titrating upward, but I always take that cautious step. I never started the full dose. And really patients value this because they have had such a lifelong history, at least in their eyes, of sweating, that they found that they could take a pill and control it. That's unbelievable to them, that they have found a medication many times that is extremely effective and well tolerated, and they're perfectly willing to take the pill on an ongoing basis, at least in the patients that I care for.
And the last thing, which I think we should let everyone know, is that there are different formulations. So there are some pills, and we know that not everybody likes to take a pill or is able to take a pill. There are liquids that people can take, and there's even a newer tablet that's come out that dissolves under the tongue. So, we can work with our patients to try to find a type of therapy that they should be able to take and to tolerate.
I'm so glad you brought that up, because I've been thinking about the use of oral medications in crush them up and put them in the iontophoresis water bath. I wonder if this new, easily dissolvable thing, I wonder if that'll work. That might make things a little bit easier for us.
Yeah, we don't know yet.
Yeah, I don't think anybody's tried. Certainly the glycopyrrolate is on most of the formularies for insurance, so it might be just easier to technically get the older product. I don't know, because I haven't tried with the new one very much yet, but the other regular glycopyrrolate, really, we don't get a lot of callbacks. I haven't had prior auth issues. Patients can go to their local pharmacy, get their prescription filled that day, and start on the medicine that day. And we can't do that with so many other medications that are new and available to us. So it's really a joy to have medicines that are available locally. And again, usually at a price point patients are willing to pay.
Yeah. And there's even a patch that's an anticholinergic that's FDA approved for urinary problems.
Yes.
I haven't used that for my hyperhidrosis patients, but but that would be something that I'd be up for if we needed to.
And Deanna, I know you're a big proponent of iontophoresis. When you prescribe iontophoresis for your palmar plantar patients, do you also automatically prescribe glycopyrrolate, or no? You wait and see?
Yeah, I just, for the simplicity, if I can get the iontophoresis to work with just plain water, I mean, that's so ubiquitous and it's so much easier. Once you have to start getting a prescription and crushing up tablets, it just adds that extra step, that extra energy. And I think everybody likes to do things as simply as possible if they can.
I would agree, but it's a nice add-on if we feel the patient is almost there, but maybe not quite. Some of the patients actually already have glycopyrrolate because they tried that before. So they might have some pills at home, and instead of not using them at all, they're willing to crush them and put them into the iontophoresis tray. So it's an option.
Definitely. And sometimes they may just need to take a small dose orally, and that may help things along. I wish we could say this is so easy and we're going to get it right the first time, but it just, each person is different, and it takes us a little bit to optimize the outcomes.
I do see one question on here that we didn't answer, and I see it in the chat, and it's talking about common OTCs or prescription meds that cause excessive sweating. So folks, since we're in the effort of time, I want you to go to our web, those who asked this question, go to our website, sweathelp.org, and take a look in the about sweating, look for secondary hyperhidrosis. We have a whole list of diseases and drugs that cause excessive sweating. Angela, any last? We're 2 minutes over, but this is amazing.
Do either of you know anything about a drug that's in the pipeline? Someone's asking about Theravidas. It's THVD 102. I'm not sure whether that might be hard to pin down right now.
Yeah, there is a drug, and it's a mixture of an anticholinergic and a cholinergic with pilocarpine to help reduce the dry mouth. But to my knowledge, the company has not been involved in any further research after a very small pilot study that was done, I think, prior to COVID. So hopefully maybe we'll start to see some movement forward from that company now that life is semi getting back to normal.
Right. And we have towards the end of last year, we have a blog 3 blogs all about what's in the pipeline for hyperhidrosis. So check that out. You'll see some really cool things. Some things are oral medications, some, this is a global report on what's in the pipeline for hyperhidrosis. So look there. And if any of you have questions about any of the references that I have mentioned, please, you can send me an email. I am ljp@sweathelp.org. I would just like to thank Angela and Dr. Hebert and Dr. Glaser. Thank you so much for joining us today. And thank you for all of you from around the world who joined us, some in the middle of the night, some in the early morning. And also thank you to Edenbridge Pharmaceuticals for supporting this program through an unrestricted educational grant. I have wanted to do this program for years. More information about treatment options for excessive sweating is available on sweathelp.org, and any new information garnered from this discussion will be included on sweathelp.org shortly. Healthcare providers that are on this webinar are encouraged to register with us in our clinician finder and to attend our masterclass in Charleston, South Carolina on November 5th. Thank you so much. The full and official announcement will be going out shortly. Thank you again from my heart to yours. Thank you.
And thanks to Lisa for always putting everyone up front and doing everything to make everyone have the best outcomes and experiences with this disease. So thank you, Lisa.
Yes.
Thank you.
Thank you very much.
Oh, it's an honor. Okay, off we go. Let's go save some lives.
Okay.
Okay.
Bye.
Bye, everyone.
Bye.